Thank you so much, Stephanie and Mary, for those two terrific talks. Incredibly comprehensive, and I imagine very valuable for Social Security. I certainly hope so. We have a couple questions from the audience I'd like to start with before asking you a few of my own. First, I'll direct this one to Mary. How much does transplantation improve survival compared to standard of care for patients with multiple myeloma?
Oh, well,
sorry,
thanks
Mary.
for asking me a non-controversial question. So it's very clear that that autologous transplantation improves progression-free survival after multiple myeloma. With differences in the median progression-free survival of more than a couple of years. Whether it actually improves overall survival compared to sequential transplantation, sequential therapy over, starting with conventional therapy and delaying auto transplant to later is controversial. But I think whether you do it earlier, whether you do it later, autologous transplantation is now considered part of the armamentarium of things to do in patients who can tolerate in transplant. The trials that first showed its use back in the mid 1990s clearly showed a survival advantage in patients who got an auto transplant versus what was conventional therapy at the time. Now I think it's not so much as yes or no transplant, it's when transplant.
I think one of the reasons this was a hard question for me to ask Mary is that, as Mary said, when they first did these randomized studies of autologous transplantation versus conventional therapy, there was a clear survival advantage, which was measured in years with transplantation. But probably one could argue also CLL, but more effective new drugs have come about recently for multiple myeloma than probably for any other hematologic malignancy. And so we keep having to redo the studies where we compare transplantation to conventional chemotherapy, which makes it hard to give a single definitive answer. But one of the nice things about our field is that we keep doing those studies.
That's right. And there's a big one in progress. Well, that's already finished enrollment, and that hopefully will conclude its follow-up in the next year or so. I would say, if pertinent to this conversation, the non-transplant approaches for treating myeloma are also associated with significant disability and morbidity. So it's not all about in terms of being able to work full time or have good quality of life. They each have their impacts. So.
A second question comes from the audience, but also it was one thing that I was struck by. This would go to Stephanie. I was really impressed by the similarity between autologous and allogeneic transplant long-term outcomes. If you had asked me before I saw the data, I think most of us would have expected the symptom burden to be much higher after allogeneic transplantation than autologous transplantation. Can you expand on those findings and why you think they're so similar?
I think that's a great question, Fred, and I think you're right. A lot of us taking care of these patients would have thought that the autos would be doing a lot better than the allogeneic recipients. Maybe that just reflects our own perspective and our bias, because when you actually ask them and when you actually look at their comorbidities, they're much more similar than different. Maybe that, a lot of this could be from the pre-transplant treatment, which can be sometimes more similar between the autos and the allos. It could be the high dose chemo, like just the transplant, which right at the time could be similar between the autos and the allos. And also, being immunocompromised and having increased rates of cardiovascular disease and some of these other comorbidities is a lot higher in the autos than you might think. So I think it might be sort of a combination of things, but I did clearly want to make that point because I think that is a bias out there that our autologous survivors should be doing a lot better than our allos. And in many dimensions, that is not the case. They're more similar than different.
Thanks. Go ahead, Mary.
I would say that the other thing to consider is that after allogeneic transplantation, ongoing maintenance therapy for the underlying malignancy is uncommon, but it is pretty common, particularly in the myeloma setting. And so there are some impacts on quality of life and functional status from that ongoing maintenance therapy as well. So it's not just about the transplant, it's the need for ongoing therapy. And also in the lymphoma setting, these are very often patients who have failed their first round of, you're getting cumulative effects of various rounds of therapy. That's true in the allo setting too, where only about 40% of the transplants are being done as upfront therapy. The others are being done as salvage therapy. And so you have the cumulative effect of multiple courses of anti-cancer therapy on the patient's functional status and well-being.
Mm-hmm.
So this is a question from Adrian Formentos, who asks, given all this, what would you say in answer to the question, why would I ever do a transplant? Now, I can start a little bit.
Yeah.
And let me just say that neither Mary nor Stephanie ever sugarcoat anything. They are absolutely straight shooters about the data and don't over-promise with anything. And actually, they were asked to talk about disabilities. For many, many of our transplants, transplantation is the only opportunity to cure. These patients are going to die from their underlying disease if they don't get a transplant. That is certainly not always the case, but in many of the cases of acute myeloid leukemia, for example, that Mary was referring to earlier on, patients with high-risk AML have a cure rate of maybe 20% in first remission, and once they relapse, there's no chance for cure. But transplantation offers them a real opportunity for cure in those circumstances. So for many of the circumstances, we're talking about cure versus no cure. There are other situations, however, like multiple myeloma, where it is extending life, but at a cost. But Mary and Stephanie, would you both like to comment?
Yeah, I'll comment that, we were focusing on disability, but as Fred says, many patients are cured with this therapy, and many of them actually have reasonably good quality of life. What's striking is that when you ask them about their quality of life, overall, it's pretty good. It's when you start asking about specific symptoms, specific difficulties. And I think the reason the quality of life is good overall is because they are looking at the alternative, which is death and no quality of life. But also people are very resilient and they can adapt to new normals and find things that are meaningful in their life, even though it is not what it would have been if they had frankly never gotten their leukemia and then had to have a transplant. So I think it has to be taken in that context. I just went through a bunch of, we always ask our patients every year to send comments, and many of them will tell us about, their difficulties, but also, the beauty that they found in life after a transplant and how thankful they actually are that they were able to have a transplant and see their grandkids and their kids grow up. So
that's really an important point, Stephanie. Thank you. Mary?
I would say that we actually did do a study asking patients whether they regretted their decision, and only a small minority have what's called decisional regret about going through with the transplant, even those whose disease came back, even those who relapsed afterwards. So I think being able to go back to work isn't everything, and specific disabilities do not prevent people from having a fulfilling and a happy life. So we are focused on disability here, but that's not the whole picture, as Stephanie pointed out.
Another question, this probably doesn't go to either Stephanie or Mary. This goes to someone, I think, at Social Security. The question is, are there medical specialists on the bodies which review the CDRs? So are there transplant specialists that are reviewing the continuing disability review, doing the continued disability reviews. I'm not sure if anyone from, I guess we're not going to get an answer from them. Maybe later in the day we can hear more about that. Mary, you were talking about the fact that only about maybe a half of the patients with AML who should get a transplant are getting a transplant. This is something that I looked at as well sometime earlier. What do you think are the major reasons for that? Number one. Number two, what do you think can be done to overcome that? And number three, also related to that, is this a problem that we have with inclusion of minorities and racial and ethnic minorities?
Well, there are many different reasons. You know, one thing is I think that the general knowledge about the successful outcomes with mismatched transplants have not yet adequately disseminated into the referring oncology community. There are still many oncologists who don't think that you can get have a successful transplant unless you have a fully matched donor. And I think that will change over the next few years, hopefully. But many of the barriers now have to do with general barriers to high intensive medical therapy. And these are barriers of geography, because you can't get a transplant at the hospital down the street. They are barriers of economics. You can't travel, or you don't have adequate insurance to cover these procedures, and to cover not only your own travel, but people need a caretaker, and that caretaker may be the breadwinner for the family. There are certainly issues of disparities in access based on race and ethnicity and socioeconomics that get intensified when you talk about an intensive therapy like this. And so there are those barriers. So I think even if everyone agreed that everyone has a donor, we would still see disparities in access. And you know how I know that is true is because we're not doing as many auto transplants as we should do either, although the difference is not as great. But there's no donor issue there.
Thanks, Mary. Stephanie, in your talk, you had on one of your slides sort of a prediction that this problem of disability after transplant was possibly going to get worse, not better, in part perhaps because of the aging population that's treated. On the other hand, you know, we do have much better ways of preventing chronic graft-versus-host, for example. I think that post-transplant toxin has been remarkable in decreasing it. And as you know, naive T-cell depletion looks incredibly encouraging in the same vein. So do you think that in balance, you're still going to bet on worse disabilities going forward? And if so, what are your thoughts about methods for preventing disability and helping patients recover?
Yeah. Well, no one has a crystal ball, Fred. So, of course, we'll have to see. We all hope that chronic graft-versus-host disease and some of these other things go away, but also we're doing more transplants. And so it's possible that even though we're decreasing some of the complications, the overall number of disabled people will go up. I think we're also seeing supportive care is so good. I made this point that actually, I think, you know, some of the patients that would have died 5 or 10 years ago are surviving. And so they could be in poor health. You know, whatever doesn't kill you can certainly make you disabled. You know, in terms of things we can do to prevent, we're always, as you mentioned, you know, better graft versus host disease prophylaxis. There's also, I think, a lot of work trying to do things like prehabilitation. So trying to get patients stronger before they come in, trying to make sure that we keep them mobile, trying to rehab them more aggressively afterwards so that, you know, sort of no matter where the patient is, trying to get them to better functional status. And those studies are actively going on and might help things. So it's hard to know in some. We obviously want to have more patients survive. And as Mary said, you know, disability is and not working is not the end all and be all. But I am seeing a lot of patients who, unfortunately are surviving, but can be quite disabled afterwards.
So, Stephanie, I'm going to follow up on my question. As someone who does research in this area, do you think if Social Security or someone invested money in research to overcome disabilities, it would be cost effective for them in the long run?
Whoa, of course. Prevention is always better than cure, right? Prevention is always better than cure. I think that there are those studies going on, probably not from Social Security Disability Index, but NIH is funding some of those studies. Prevention is always better than cure. And if you can't prevent, at least you can detect it early and do something about it. So yes, I'm pleased to see that we're not just thinking about survival, non-survival, but we're also thinking about quality of life.
And again, for the non-experts who are listening, we talked about a lot of different kinds of transplants. We said that there wasn't that much difference between auto and allo. What about cord versus unrelated donor versus haplo now? Are we seeing a lot of differences in disabilities based on the source of the stem cells?
I guess I can take that one, Mary, and then you can comment. Those haplos and cords are a little bit, in terms of the trajectory of transplant, more recent development. So we don't have, this 30 and 40 year kind of survival data. With some of these GVHD prophylaxis regimens, I think chronic graft-versus-host disease rates are lower. And so hopefully that will translate to better long-term outcomes for some of these graft sources. But we don't have too much hard data yet.
Mary, do you want to comment?
I would say in terms of donor source, it's probably still best to have a matched donor, but the differences are modest at best. And I don't see any real reason to think that the long-term disability rates will be substantially different, not in ways that will affect the prevalence of patients with disabilities in a meaningful way from a Social Security Administration point of view. Some of these developments in GVHD prophylaxis with post-transplant cyclophosphamide and T-cell depletion are counterbalanced by the fact that we are increasing our use of collecting cells by apheresis, and that is associated with more chronic graft-versus-host disease, maybe not with T-cell depletion, but with other forms of GVHD prophylaxis, including post-transplant cyclophosphamide. And there's a lot of reasons for that. It's a question of early versus late problems. But I think from, not the 30,000, but even the 10 or 5,000 foot view, there's not a reason to really differentiate the estimation of disability depending on the graft or donor source.
And this is a question from the audience, but it's something also that you touched on, Mary, and that is that many patients are disabled from their initial therapy, not from the transplant, but right. They have some disability from getting high-dose ARC for their AML or others. So how much of the disability after transplant is predictable from from some kind of index before transplant?
Yes, so we're talking about, there's disability and there's quality of life, and I don't know that, many patients are considered, quote, disabled while they're getting their cancer treatment. That doesn't mean that they would be disabled long term, but I can tell you that if you look at the transplant population, 75% of them have at least one comorbidity unrelated to not counting their cancer. So they and more than half have 3 or more identified comorbidities as measured by the HCT comorbidity scale. So that's, cardiac problems, lung problems, depression, et cetera. So they're coming in with a lot of comorbidities. When that study that I showed you that showed a survival advantage of transplant versus non-transplant therapy for myelodysplasia, actually the quality of life of the patients who received transplant and non-transplant therapy was virtually identical post therapy, implying that some of these quality of life deficits are irrespective of the therapy. So much of it, so like I said, so if you look at acute leukemia, 40 to 50% of these transplants are done in first remission, so upfront before they have a whole lot of other therapy, but others are being done after they've failed multiple things, and those things have cumulative effects. Same thing with lymphoma. So we're dealing with an intensive therapy applied in a population that is already sick. Now, I think Stephanie did talk to this quite a bit in her talk about poor quality of life pre-transplant predicts poor quality of life post-transplant. So I think that we can assume that those who come in non-medical term beaten up by all of their prior therapy or by other medical conditions are more likely to be disabled post-transplant. Stephanie, you want to comment on that? You actually presented some really nice data.
Yeah, exactly. But I also want to make the point, though, that even though these patients are coming in, many of them disabled, for sure we can see a huge increase in post-transplant comorbidities. Yeah. Cardiovascular disease, pulmonary, diabetes, all sorts of things. So I don't want people to think it's all pre-transplant. We can clearly see an effect of the transplant as well.
I just want to say that this question asked about the onset date. I mean, in terms of being disabled for a year, I would say the onset date is from the start of therapy, whether it's transplant therapy or not. Because it's all part of a continuum of the care of the patient.
Thanks, Mary. We did get some clarification from Adriana. She says that this is a comment from Social Security Administration that they do have medical consultants who provide advice on their continuing disability review decisions. But these medical consultants are unique to the state disability determination services, and there isn't specific information on their backgrounds. There may be some medical consultants with a stem cell treatment background, but at least the background and the prevalence of that is not known. So that answers one of the earlier questions. So we don't really have a complete answer to that. Another question from the audience. Is the lack of difference between allo and auto transplant, is that going to affect indications in other conditions like sickle cell anemia? I mean, if you did an allogeneic transplant for sickle cell, would you expect that the disability later on would be similar to what will happen if we get gene therapy and do auto transplants with gene therapy correction?
Yes, and first of all, we're talking in looking down from 30,000 feet here.
Yeah.
Okay, so there are certainly some populations, particularly in the non-malignant disease, where the functional status post-treatment is excellent. You do an allotransplant for a young person with newly diagnosed aplastic anemia or an infant with sickle cell. Not only are their survival rates up in the 90+%, but their quality of life is also excellent. Now that's in a very small group. So we're not doing nuance here. We're doing very big pictures. So if you want to talk about very specific diseases, then you have to get a little bit more granular. There are certainly similarities in gene therapy with high dose alkylating agents, where one might expect some of the same long-term complications. But some transplants for sickle cell anemia use very reduced intensity conditioning regimens, and while they have some GVHD, may not have those others. So, Stephanie, you want to comment on that?
No, I agree with you, Mary. I mean, I think certainly when you compare it to what sickle cell disease would do without transplant or gene therapy, you're really improving disability. But, right. A lot of these ways that we do sickle cell disease transplants, we're really trying to avoid any kind of graft versus host disease, right? Because they don't need that to keep their disease away. And so, I think some of the newer regimens, the rate of chronic GVHD is very low. And so the outcome might be very similar between gene therapy and transplant.
Great. Any last thoughts you want to share with us, Mary?
No, I think not really. I just do want to say the comment about why people would get a transplant, and that this is a curative therapy for many patients, and most patients, even if they can't return to work, do return to a reasonable quality of life.
And I amen to that. And I also want to echo what Stephanie said before, that disability and people's perception of the quality of their life are not the same thing. There are people who have remarkably few disabilities and will still say their quality of life isn't what they want. And there's some people who have significant disabilities and say their quality of life is outstanding, which is, I think, a point Stephanie made, and I think bears repeating. This is a curative therapy for many of these diseases. Stephanie?
I don't think, nothing else, Fred, you said it.
Okay. All right. Well, I want to thank Mary and Stephanie for terrific talks and really insightful discussion. And I also want to thank the audience for their questions. And with that, we're going to move on to session 2. Thank you.